This is a 50-year-old woman who presented with 6 months of behavioral changes. MRI demonstrated a large olfactory root meningioma with associated edema and hyperostosis of the anterior cranial fossa. We decided then to proceed with an endoscopic endonasal transcribiform approach. The tumor remained predominantly medial to the plane of the medial orbital wall, while the angle between the orbital roof and the olfactory roof was very deep and provided a very unfavorable trajectory for an anterolateral transcranial approach. Then the endonasal route was discussed and decided to proceed in this case. This cadaveric dissection demonstrates the relevant anatomy. The endonasal approach provides early access to the anterior and posterior ethmoidal arteries, also allowing for early tumor devascularization and the possibility of achieving a Simpson grade 1. After drilling the anterior cranial fossa, we can identify the dura, olfactory fibers, and the ethmoidal arteries. However, this approach has certain limitations. So, tumor involved in the anterior third of the olfactory groove can be difficult to reach and may require a 30 degrees endoscope. In addition, the reconstruction may also be challenging because the nasoseptal flap needs to be long enough to cover the very anterior defects. As we said, the medial orbital wall represents an important lateral limit. Tumor extending beyond this plane are more challenging because surgical freedom is limited by the angle between the contralateral nostril and the ipsilateral medial orbital wall. We have some tricks, however, to increase the exposure. Lamina Papyracea can be drilled out until exposing the periorbita, and then both ethmoidal arteries are ligated, and the periorbita can be retracted laterally to gain few extra millimeters to reach and go even above the orbital roof. Here we have summarized the key surgical steps. Dr. Stavridis started the case by infiltrating the middle turbinate. After medializing the middle turbinate, we can identify the posterior ethmoidal cells, and then real medialization towards the septum exposed the middle meatus. Now, once in the middle meatus, he used a backbiter through which he opened the uncinate process, providing access to the maxillary sinus. Here we can appreciate the relationship between the maxillary sinus and the bulla ethmoidalis, which represent the largest anterior ethmoidal cells. A J curette was then used to remove the bulla ethmoidalis. We can also identify the relationship between the middle turbinate and its attachment to the skull base. The middle turbinate is then removed. The same steps were then performed on the contralateral side by Dr. Stavridis. Next, a vascularized nasoseptal flap was harvested using the standard anatomical landmarks. The inferior incision was initiated at the choanal arch and then is extended along the posterior septum towards the floor of the nasal cavity. Here we can appreciate the relative position of the incision with the posterior aspect of the inferior turbinate. Once at the inferior meatus, the incision is carried anteriorly to the lumen nasi. A two-pericontrol dissection was then performed to elevate the nasoseptal flap. And then in the contralateral side, Dr. Stavridis completed a wide septostomy. The dissection was completed posteriorly to expose the esophageal rostrum. The bone is removed, wide esphenotomy is complete. After removing the posterior ethmoidal cells, we identified extensive hyperostosis resulting from the tumor-associated bony reaction. This bone is often highly vascularized and can bleed significantly. Therefore, I use a high-speed drill to progressively devascularize and remove the hyperostotic bone. I usually begin the drilling with a diamond burr to minimize the risk of injuring the anterior and posterior ethmoidal arteries. Drilling continued until the dura was exposed on both sides of the crystic alley. We then identified the canals of the anterior and posterior ethmoidal arteries. The bony removal was maximized laterally towards the orbital roof without violating the lamina papyracea. In this case, removal of the lamina papyracea was not necessary because most of the tumor remained medial to the medial orbital wall. Nevertheless, it's important to maximize the lateral exposure while preserving the lamina papyracea to avoid orbital injury. Drilling was continued with the diamond burr while carefully controlling the vascularity of the hyperostotic bone. Here we can identify the canal containing the posterior ethmoidal arteries. The remaining hyperostotic crystic alley and calcified portion of the tumor were removed with a curette. I then used a bipolar sealer in this case to achieve rapid tumor devascularization while minimizing thermal injury to the underlying brain.
Dura was open in the midline, and an initial specimen was obtained for frozen section. Internal tumor debulking was then performed with the sonopet. However, in this case, I prefer to use a side cannon aspirator because of its lower profile and greater maneuverability. We then focus on the most critical portion of the dissection because of its relationship with the optic chiasm and the anterior cerebral artery and anterior communicating complex. After adequate internal debulking and devascularization, I gently elevate the tumor capsule, and rather than applying direct traction to a portion of the capsule located within a blind spot, I introduce this cottonoid to provide contraction and reduce the risk of disrupting the underlying vessels and perforators. A 0 degrees endoscope was used. The endoscoping instruments were arranged at different levels within the nasal corridor to avoid instrument conflict. As I proceed from lateral to medial, I progressively advance the cottonoid behind the tumor to maintain the dissection plane and avoid tearing of the vessels. Once the arachnoid plane was identified, I continue with a combination of blunt and sharp dissection. The same maneuver was then performed along the most lateral aspect of the tumor. Although this portion of the tumor extends slightly lateral to the main surgical corridor, removal of the lamina Papyracea was not required. Using a number 1 angle dissector, I performed a rotational maneuver, following by further internal debulking to progressively roll the tumor capsule into the surgical corridor. Here we can identify some small branches that were not initially visible along the frontal lobe. It's important to maintain the orientation between the midline and the most lateral aspect of the tumor. Here we can identify the anterior hemispheric fissure. By controlling the tumor laterally and understanding our position relative to the midline, we can avoid the main branches of the anterior communicating complex. I continue using a combination of sharp and blunt dissection, leaving the final midline attachment until the end to minimize the risk of injury at the anterior communicating complex. The arachnoid plane is frequently preserved. With patient, progressive debulking, and careful rolling of the capsule, the tumor can be removed in its entirety. After tumor removal, the frontal lobe began to descend into the surgical cavity. So then I created a scaffold with Surgicel, and I used limited coagulation to prevent further collapse. We then performed a multi-layer reconstruction using collagen matrix, fascia lata, and the vascularized flap. The fascia lata is placed in an onlay fashion over the dura margins, but is stuck under the bone defect for support. The flap had been excellently harvested by Dr. Estebrives and had sufficiently length to cover the entire anterior cranial fossa defect. Additional Surgicel was placed as a supporting layer, following by fibrin glue. Postoperative MRI demonstrated cross-total resection consistent with a Simpson grade 1 removal, with excellent apposition of the Nasoseptal flap. The patient developed no new postoperative neurological deficits and remains tumor-free at 3 years follow-up. To conclude, remember 2 key surgical principles. First, when working within a blind spot, avoid the retraction of the tumor capsule. Instead, introduce a cottonoid to provide gentle contraction and protect the underlying vessel and perforators. Second, carefully evaluate the relationship between the tumor and the medial orbital wall, as this is a key factor in determining the feasibility of the endoscopic endonasal approach. When additional lateral exposure is required, and you still want to go with an endoscopic endonasal approach, removal of the lamina Papyracea can provide a few extra millimeters, but have a very low threshold to change your approach to an anterolateral transcranial approach or a transbasal approach. Thank you for watching. If you found this video useful, please share it with your colleagues and let me know how this content could be improved. Thank you and have a nice week.